So Irani, now that we've got this context, a new virus, it's in a number of patients. From a clinical perspective, what are the obstacles that you see, whether it's research and ethics or healthcare, occupational health and safety, all those range of questions that you're immediately concerned about when there's a new pathogen?
Well, all those questions are going to, firstly, there's going to be safety, so safety of healthcare and staff that are looking after, laboratory personnel who are going to be looking at these samples. When we're dealing with a new virus, and we might be asking to look at this virus in a novel virus in a new sample, we don't know the implications of what that means for the lab staff, for example, looking after it. So there's going to be a lot of, I guess, questions that will come up when trying to work up what the implications of the virus are. But in the spirit of exactly this, so Mike mentioned that when Zika came along, there was a lot of steps towards doing testing in new samples. Well, I think when Zika came along, we started to think a little bit as well about having platforms in place within hospitals, within tertiary hospitals, so that if a novel virus was to come along, there was already a framework in place to be able to sample and sample fairly freely with all of the ethical support to be able to do the sampling. And so we have that platform in place at the Royal Melbourne, and we're certainly looking to move up that kind of platform to other hospitals to be able to really do exactly the kind of research that we're talking about in this kind of situation.
Yep, that's great. Okay, so a week into the illness, Jill is now recovering. She's out of intensive care, and Jack and Steve's sample is also positive in the Vidril test for Borna virus. So, Mike, is Health Department notified at this stage, or is it kept quiet for publication?
I was sitting there listening to Irani talk, thinking the one thing I didn't say before, I'm sitting next to Australia's chief, and I haven't said that even after one case of Borna virus, never mind a cluster, there'd be a courtesy call down to Chief Health Officer of Victoria. I mean, it's not a Commonwealth issue at this point, but and the chief health officers of each state have communication mechanisms in real time anyway through committees, for instance, that meet regularly. So they've got a network of letting other people that need to know. So of course, just with one case, a courtesy call, it's not a notifiable disease, but just we've got something funny. Certainly when there's a cluster, absolutely, it's a public health issue now, and probably there'd be some sort of an incident management team at the health department that we'd be working with, just the clinicians and the lab people and the health department working through what issues there might be, thinking about messaging, thinking about the community and any risk. Something I was on my mental list to mention was, it's a horse virus. They were up in rural Victoria. Okay, where did this come from? If we're thinking about the community and what we're going to tell the community, it would be nice to put some resources to some sampling of animals and seeing if we could establish how you get it, because that's going to be a key question early on. Okay.
Okay, Brendan, as Chief Medical Officer of Australia, you've just heard about this event from the state health jurisdiction. No one's died. We have low numbers, a few severe cases, and further suspected cases. So what's the trigger point for DOH to get involved and in such an event, and what's happening in the minds of the Department of Health?
Okay, so as you know, we're a very happy federation that works extremely well. So I would have been notified probably within hours of my Victorian counterparts being notified, and clearly the public health, initial public health response is at the state level, but we have a very, as Mike said, we have a very active network of collaboration. So the novel virus would raise our alarm bells. In the Commonwealth Department, we would establish a small rapid assessment team, probably look up Dr. Google as well, and we would obviously want to find out whether Victoria needed any help. It's unlikely they would need any help at this stage. We would want to work out what sort of communication strategy. It would probably be a Victorian-led communication strategy, although we'd want to understand the potential exposure. How many people were at this music festival? They have gone back to every state in the country. It's almost inconceivable that any containment is possible at this stage. The festival's over, so my wonderful powers under the Biosecurity Act that need to be exercised. But We would engage CDNA, the Communicable Disease Network Australia, inform them, and we'd make sure that the Victorian labs had probably sent some samples to CDC in the US. We'd like to do that fairly early on. And as a courtesy, we would notify WHO, but it's not at the stage of a public health incidence of international significance, probably not even a communicable disease of national significance in Australia yet. So we would keep a watching brief and see what evolves at this stage.
Yep. Okay, thank you. So at Vidril, here in the Doherty, whole genome sequencing from a number of patients is completed, and it shows the virus to be a recombinant form of a Borna virus between a horse Borna virus and another Borna virus of unknown origin. Isolation or culture of the virus is attempted, but not successful. We even go to Liz Neat in the audience, who's sitting here, and we try her organoids, and we are still unsuccessful. So we can't grow the virus, but because we have the additional sequence, we have a rapid, specific, real-time PCR design for rapid diagnosis. Mike, with a highly regulated pathology sector in Australia, how is testing implemented and what are the hurdles?
Okay. This would be any test that we're doing on people has to be accredited within your scope of practice, for me as a pathologist and for my staff. So there'd be two regulators that would be interested in that. One of them is the National Association of Testing Authorities, or NATA, that provide the accreditation that we operate our human testing. The other's Australia's equivalent of the FDA, the Therapeutic Goods Administration in Canberra. They have a scheme legislating the accreditation both of commercial tests, so every test that is bought off the shelf and used in a lab, or any test that the lab invents themselves, have to be on a database at TGA and accredited with them. So there's been a lot of thought about, well, what do you do in events where you quickly need something? We are set up so that we have the ability to test, to validate, and to report outside of our everyday NATA scope. So we have a little test report format that says this is not a NATA accredited test. And so we could just test and provide reports to clinicians on that basis. I think the expectation would be that you would assemble a dossier and present data to NATA and in a reasonably timely manner get accreditation for the test. So we'd be working towards that, but that's not your focus at the moment, which is about the patient and the public health. Likewise, TGA, really a test like this is not a really highly regulated test of a lethal agent, so we'd have the freedom to use the test in what's called an in vitro diagnostic device until June 30 of that year, when we notify TGA of all the new tests we've invented. And I think what we would do is, through our colleagues at a group called the Public Health Laboratory Network of Australia, we'd be, and much earlier than this, we'd have let them know as part of the response that we had something going on so that they were aware. We'd be sharing the information that we've got, and we will be working closely with Brendan's department and the TGA, I think, in a dialogue about, well, we're using this test, it's not an accredited test. How will we work to fulfil TGA's requirements, yet get the public health and lab capacity that's needed? The one rub would be that if the Vidril test is needed outside Victoria and we had to share it with anyone, that casts us in the role of manufacturer, which is pretty onerous with the TGA. And this is actually playing out at the moment with highly drug-resistant gonorrhea and antibiotic testing, and that there's a very good test for it invented by David Wiley in Queensland, and the TGA are considering the basis on which that could be shared amongst the state jurisdictions, and there's been discussion with Brendan's department and TGA about that. So not insignificant issues. I mean, obviously the main game is the patient and public health, but you do have to do it within the framework of the law. So we'd be trying to balance those.
Yep. Okay, so Borna virus cases continue to expand. We have 10 severe cases in the first 2 weeks, 50 by the third week. Intensive care units in Melbourne are overwhelmed, and there are suggestions that there are many more milder cases with severe headaches within families that have cases. So increasing numbers of these are tested, and are indeed found to be positive. Brendan, when do we issue a health advisory, and what makes a virus become notifiable?
Well, I think there are two different questions. I think this is clearly now a communicable disease of national significance. It's got the features of novel virus and rapid spreading. So we would CDNA would convene one of their rapid incident teams, do a quick analysis. We would get AHPPC, the Chief Health Officers Peak Committee together, and we would declare there's a communicable disease of national significance. We would obviously engage Public Health Laboratory Network. Because it's of that size, it probably needs a national communication strategy that we would work closely with Victoria to develop, and using the same sort of WHO rules that what we know, what we don't know, what we're doing, and what you can do to protect yourself. So we'd be very carefully crafting that communication strategy. It would require a formal notification to WHO because of the significance of this. Probably still not a public health emergency of international concern, but it's potentially bordering on it. The question about what makes a disease notifiable, really the question is, what is making it notifiable going to benefit our public health response? There are a whole lot of criteria for making a disease notifiable. It's got to be notifiable both at the Commonwealth and the state level to be effective. Those criteria can be waived. The Commonwealth and the state health ministers have the right to make it notifiable, but you've got to think about whether the concern and awareness in the community and the testing labs is probably so high that it probably isn't a great priority to make it notifiable. I think the most important thing is to coordinate the public health response, the laboratory response, and the communication to the public.
Yep. So, Katherine, infectious diseases physician and epidemiologist, you talked to Irani and Mike just out here in the foyer. The numbers are expanding. What are the first questions an epidemiologist asks?
So the first question we always ask in an outbreak is it real? Because quite often, particularly with media reporting, you can get clusters and things that end up being nothing. But if we have a laboratory diagnosis of a novel agent and there are an expanding number of cases, then yes, it is real. The next thing we want to ascertain is kind of the scope and the spread of the outbreak. To do that, we'd need a case definition. So when there is a confirmed laboratory diagnosis, that's easy, but if we don't have a serological test and we're relying on people shedding virus at the time that we're testing, we might need to have a broader case definition. We'd like to know both about the severe cases, the mild cases, but also if there are people who are infected and infectious but are not demonstrating symptoms. So that would be having to work very closely. We'd do some active case finding. And this is where having a coordinated national approach is important, and having communications on board early is important. So we'd be putting out a call for people to diagnose and let us know about these cases. And that might be through, we've already mentioned a couple of, a laboratory network, PHLN, the public health network, CDNA. Maybe we could put something out on AusBug to target infectious diseases physicians. Could be Chief Health Officer alerts to target GPs and diagnoses. And it could be a media call as well, so that cases themselves can come forward and be counted. And once we have that, not only do we know where it is, we also know who's being affected. And that can give us some clues about how it might be spread and the sorts of things we can do to try and prevent ongoing spread, because that's going to be the focus.
Yeah. So mode of transmission is obviously important. We assume from the horse model that it's an enterically spread virus. Hand hygiene controls and alerts to clinical services, is that enhanced or is that satisfactory currently? Or
you'd hope it would be
Yep.
satisfactory currently.
So what about in the home?
We might remind people, so
Yeah,
if you think it's a fecal oral spread, then certainly the important thing is to let people know, these things early on, and particularly if it's something like that you can just promote without there really being a downside, then for sure we'd be promoting that. By the time you're invoking quarantine of people, you have to be a lot more sure that you're
Yeah.
that you're doing the right thing.
So kind of all infections have a reproduction rate, like the mechanism of spread is linked to how many people one infected individual spreads to. So in order to calculate that value, how do we go about that?
So I guess you've defined it so that it's if you have one infected person who comes in contact with an uninfected population, how many people on average will they infect? And in order for it to be an outbreak, that number needs to be more than one. So a good way of doing that, just a very basic sort of idea, is to look at an epi curve, so to plot cases by date, a number of cases by date, and just to get an idea of how rapidly things are rising or falling, so an outbreak curve, and that will also sometimes give you some clues about the transmission as well, whether it's a point source or whether there's ongoing propagation throughout.
Yeah. Okay, thank you. Fabian, Sharon Lewin, the Doherty Institute Director, calls a group meeting, including you. From an immunologist's perspective, what are the first questions you are interested in, and what do you need to answer these questions?
I think there's questions both sides, not just from an immunologist's point of view, but also from a microbiologist's point of view. There's two things there. The first thing is, of course, when we hear from our colleagues, what's happening to the patients. You're wondering about the immune system of the patients, why isn't the immune system in some ways controlling that? So there's something that's happening. You might want to suspect that maybe or maybe not, and we just want to know whether the immune system is or isn't affected by the presence of the virus. Some virus can compromise some aspect of immunity. We might want to look at that. The fact that it's pretty local, or at least it seems to be CNS specific, that you may or may not have things like that. But from the microbiology point of view, it's really understanding the virus and being able to develop models where we can study the propagation of the virus. If we can in rodents or maybe in a non-human primate or something, to get a feel for the progression and how the immune system reacts to that. But I'm hearing that it's pretty difficult to passage that virus. So I think the first problem is trying to find a system that's going to help us have access to enough material to study the virus. So unlike my colleagues, I wouldn't do Google. I would go to the peer-reviewed databases. And certainly there's not a great deal known about this Borna virus, but there are a few clues here that we would explore. One clue, which is very important from our colleague clinicians, they tell us these things seems to have an impact on the CNS, central nervous system. We try to get some materials under human, ethic conditions, being part of collaborations, working with clinicians. The CSF is a good start, probably not a lot there, but we could start with that. And then find a system where we think the virus might be able to propagate. So I understand it's very complicated, visual. Our colleagues have tried, it's been very difficult. But then the literature tells us something. The virus is in the CNS because of a reason. It's because the CNS cells are providing an environment that is better for the virus to propagate. So what is it? So looking at the literature on Borna virus, you realize that in the CNS, there's an enzyme expressed called protein kinase C epsilon. That seems to be important for the virus. So that's how we're going to think. We're going to think, well, what if this virus needs that too? Can we create a cell line overexpressing this enzyme that could be a good model of propagation of the virus? So we'll start simple with things like that. We'll try to engineer a cell line, maybe of CNS origin if we can have had, or something that responds to a nerve growth factor, like a PC12, cell line, and then try to engineer that to express that enzyme that might help the virus propagate. So first thing. It may or may not work. If it works all great, we can start ask our microbiologists to study the virus, look at the genome and other things and how it works and how it affects. If that doesn't work, what we can do is we have colleagues here at the university, especially Dr. Alice Pebe. She's able to differentiate human stem cells into mini brains. And maybe those mini brains cultures are able to propagate the virus a bit better than normal cultures. But we'll try that first.
We'll try that. Okay.